So we are live again from the AIOS All India Ophthalmic Society Secretariat. And we again are going to have yet another surgeonar today, and this surgeonar is with a difference. Just to introduce the same, this is a surgeonar on new technologies in premium intraocular lenses, and the live relay will be from Rawat Eye and Phaco Surgery Center, Jaipur. The surgeonar is sponsored by Biotech and Toshpro both. So the chairpersons are Dr. Lalit Verma, who is the president of All India Ophthalmological Society, and Dr. Harbans Lal, the president-elect of All India Ophthalmological Society, who would be joining us very soon. I have with me my co-moderator, Professor Rajesh Sinha, who is the honorary treasurer of All India Ophthalmological Society and professor of ophthalmology at Cornea, Cataract and Refractive Surgery Services at RP Center, AIIMS, New Delhi. It is a pleasure for me to introduce Dr. Harshul Tak, who is member ARC Central Zone at All India Ophthalmological Society, assistant editor of Indian Journal of Ophthalmology in the cataract section, treasurer of the Rajasthan Ophthalmological Society, executive member of Indian Intraocular Implant and Refractive Surgery Society, governing council member of Indian Society of Cornea and Keratorefractive Surgeons. He's been awarded with Shurveer Singh Gold Medal for Best Paper presentation in 2008 in Rajasthan Ophthalmic Society Conference, Surya Narayan Gold Medal for Best Video Film at Jaipur 2010 Annual Rajasthan Ophthalmic Society Conference, and Best Paper of the Session Award also for his innovative technique of portholes in anterior capsule for assessment of post-op rotation of toric IOLs at the Asia Pacific Association of Cataract and Refractive Surgeons meeting held in October 2014 at Jaipur. Of course, what is not mentioned here is that he's a surgeon par excellence. He is the founder of the Life Beyond Ophthalmology Group, which is doing very well as far as the members are concerned with the extracurricular activities, and he is a great sportsman. I would request Dr. Rajesh Sinha to introduce my very good friend and batchmate, Dr. Pankaj Sharma.
Thank you, ma'am. It's a great pleasure introducing Dr. Pankaj Sharma, who is again a top-class surgeon. He's professor of ophthalmology at SMS Medical College and Hospital, specialist in cataract and corneal disease. Has been trained earlier at RP Center. It's one of our own learners. He has 24 publications to his credit. He has original published research on trap and blue injection into capsular bag to reduce post-op PCO in phaco surgery, endonucleation chop technique in hard brown cataracts, and modified stromal pocket hydration for phaco wound closure. He has been invited guest faculty in national and state conferences, and he has won numerous awards in video presentations and at OPL at Rajasthan. And he is a wonderful teacher, and when he demonstrates any surgery, he demonstrates each and every step very clearly and crisply. So thank you very much, Dr. Pankaj Sharma, for being here to show your live surgery to all of us.
It is a great pleasure to introduce the third surgeon of the day that we have, Dr. Mayank Agarwal, Honorary Secretary of Jaipur Ophthalmological Society. Passed out his undergraduation from SMS Medical College, Jaipur, and has done several paper presentations in various conferences, including DOS, AIOS, Rajasthan Ophthalmic Society, and Jaipur Ophthalmic Society. He has his private practice since 2004, and he's been implanting ICLs and has been doing intraocular lens surgeries for the last many years, and he's director of Jindal Eye Hospital and Laser Center, Jaipur. So I think with this, we will hand over to Dr. Harshul Tak and the entire team of surgeons for this to be taken forward.
Thank you so much, Namrata ma'am and Rajesh sir and entire governing council of AIOS for giving this wonderful opportunity to do this surgeonar from Rawat Eye Hospital, Jaipur. And I'd also thank Dr. Pankaj and Dr. Mayank to being here and operate few cases for us. So, and thanks to Biotech and Artly for sponsoring this session. So first case which we are going to do is toric IOL implantation. And I'd like to show the case sheet first. May I request the audiovisual people to just show the case sheet? 1 minute.
If I have it, I will just share it. They have.
Yeah.
Is this the one?
The gentleman has astigmatism, is a 72-year-old male.
Yes.
We are going to operate right eye, and he has astigmatism of 1.75 diopter, and we are going to implant a toric IOL for this. And the axis of implantation in this case is 0 degree. So these are the. Can we have the microscope feed now? Microscope feed, please. Yeah. Is it clear, ma'am, and centered there?
Yes. We can
Yeah,
see it.
very well centered.
So we are going to do under topical anesthesia. So these are the marks which we have put on the slit lamp. So
These are the reference marks, Dr. Harshul. 0, 180 degree reference marks.
Yeah. So the axis is 0 degree only. So we have to put, yeah.
Okay.
Otherwise, it's support. Sorry.
Yeah.
I just want to show that suppose this patient needed implantation at 85 degree or whatever. So we just align these two marks like this. So on slit lamp, what we do is we scratch the epithelium first. You can see these scratch marks here. So even if the ink fades away, the scratch marks don't go.
Yeah.
So after that, we can put whatever axis we want. Suppose we want 80 degree, so we can put here like this, and we can align the toric IOL. But in this case, the axis is going to be the 0 degree. So we don't need to put any other extra mark. So I'm going to start. I'll make the first side port here. So there's a 1.2 mm keratome which goes in. The light mein dekhiye. And this is the, because I use bimanual, so this is the second side port. And after that, we're going to put oculan so that patient doesn't feel much.
What is that that you injected?
This is the oculan lignocaine intracameral.
Okay.
And this is my modified viscoelastic cannula. You can see it's a curved cannula which is 25 gauge and it's tapered at the end.
Mm-hmm.
You can see that it's tapered at the end. So it fits easily without any struggle through side port. I go ahead and inject viscoelastic. बस बाबूजी सीधा ही देखेंगे. हाँ हिलिए नहीं है ना. And then we are going to make main port incision. Keratome. This is the 1.8 millimeter keratome. Next. So
you normally use 1.8 millimeter incision?
Yeah. I use co-MICS, this 1.8 millimeter Phaco tip.
Okay.
And now we are going to do capsular axis. Is it centered there?
Yeah, it's.
So we all know that the sizing of capsular axis is very crucial, especially in the modern IOLs which we use, the torics, multifocal, trifocal. So it's very important that we have. See the light mein dekhiye babuji. And this is the hydro stitch cannula and the hydro dissection cannula, which light में देखेंगे बाबूजी. which I modified. So you can see that we can easily use this cannula to
Yeah, we
rotate
can see the wave of fluid going behind.
Yeah. So this is a multi-purpose cannula. This is dark hydro stitch cannula.
Nice.
So it's very useful, especially for topical cases. Phaco. So this is the easy Phaco tape, which is from Artley, and so it has a wide mouth there. You can see the nucleus is
Audiovisual team, can you put the microscope camera as the spotlight?
So I think it is on that coming as spotlight in the YouTube. It is
fine.
right.
Yeah, now it's absolutely fine. Yeah.
Okay.
So I go ahead, hold the nucleus and chop it.
So Ottilie has a very good hold, Harshul. It looks, of course, you're doing it very well. That we cannot take away that thing from you, but it holds well.
Of course, ma'am, it does help because it has a very good hold.
And the chamber also appears stable.
Yes. So right now I'm doing multiple chops here. So the advantage of the Phaco is that it gives a very good hold. Followability of pieces is very good. Basically, it has a very narrow, lumen. So that helps in decreasing surge also. That whenever oxygen breaks, there is no surge, and the infusion which comes is 6 to 7 times more than the normal Phaco tips. So all our cases are done through 1.8 millimeter, and we have lenses now, various lenses which goes through 1.8. And even if you have to enlarge the incision, there is no problem because the main advantage is the chamber stability and all those things.
Yeah, that's very true. And so what will be the size of incision that you will make for this thing, for this acrylic?
I made 1.8 millimeter. I use 1.8 millimeter keratome.
No. For the IOL implantation.
Yeah, for IOL, it depends on the IOL which you are using.
Yeah. So the one that you are using today is the acrylic toric, right?
Yes, acrylic toric, I'll have to enlarge to 2.4 almost. So you can see there is a
very nice followability of.
Yes, followability, absolutely. Rock solid anterior chamber, even at the last fragment.
I've not changed any settings last moment also because it's all there in your foot pedal. That's what Dr. Pankaj, my teacher, has taught me.
So there is a question of on what is your Phaco settings for this case?
For this case, the flow rate is 28 and vacuum is 250. Saline, please.
So there is a small fragment, I think, which we can see.
Yeah. Yes, ma'am. So that will come.
And I think it came from the side port, which usually little fragments do tend to together. That was very elegantly taken out, I must say.
You are like me thinking about it. And another advantage of using calibrated knives like I use 1.2 millimeter is that these cannulas, they go through 1.2 mm.
Okay.
So if you use that 15-degree blade, you're not sure whether you're making 1.2 or 1 or 1.4.
So you never
That's very true.
you never have to extend these incisions to.
Yes.
And with no proprietary interest, which is the make of this cannula that you're using, the
This is
bimanual?
from Artillery only, ma'am.
Artillery. Oh, okay.
Yeah.
So you have been using these bimanuals for over all the years.
Yes.
Coaxial.
Yeah, for the advantage with bimanual is of course that you don't have to worry about sub-incisional cortex. So like I finished off this side, I go ahead and change my hands and there is no sub-incisional. This is the last pieces of cortical matter.
Are you using pulse or did you use pulse or micro pulse in this? There is
Yes, I do use pulses, 40 pulses, which is there in this machine. So that helps to decrease down the amount of the Phaco power used.
So another question was which machine you are working. So just to answer that, you are working on an Otterly machine. I think this is the first time we've had Surgeon. Rajesh, do you remember having earlier on machine? I don't think.
I don't remember any other surgeon with Earthly machine.
So I think.
So before
and you're fond of doing hydroimplantation, right?
Yes, sir. So first I'll just polish the posterior capsule after I extend the main incision a bit, so that. So of course I coined this term hydroimplantation. Yeah. It was published in JCRS in 2010. So this is the IOL.
Yes.
Which has a mark there. I will just show you. So the advantage is that because of the smaller incisions we have been using for years now, we don't need the use of OVD in anterior chamber. So of course we do use OVD where it's needed, but not where it's not needed, like in this stage. And so you don't have to worry about the post-operative rotation of the IOL. So trick is to keep this cannula above the optic. So leading haptic and optic goes in.
That's a very nice demonstration.
Because or inversion of the IOL.
Yes.
Yeah. So this flipping, if the direction of the flow is towards the IOL while implantation. So it's good to above.
It's a very good trick. I think that is what happens. We always pick up some of the other, things which we also don't do. And it's a useful lesson. These marks are on the steep axis or the flat axis? I think these marks.
The flat axis, so we need to align it to the steep axis of cornea. But before I do that, I need to make sure that axis is not overlapping much. So I just go ahead and enlarge it a little bit So I maintain the NTA chamber with irrigation cannula itself and use scissor to give a cut there.
And so I think these lenses, they come in the range of +10 to +30. And astigmatic ads that we have are 1, 1.5, 2.25, 3, 3.75, 4.5, 5.25, and 6 diopters. So 6 diopters is a useful option. Rajesh, what do you say, especially when we do
enlarge the axis to appropriate size before?
Yeah, particularly when you have high astigmatism,
Very nicely done.
post-dial.
Very nicely done, Harshul.
Yeah, dial. So after you've done that, then you can rotate the lens to the axis you want. I'm just using bimanual technique to dial the lens.
Again, I don't know. I use viscoelastic. Rajesh, I don't know if you use hydro implantation and so nicely.
Yeah, very nicely done. I have done it many times, hydro implantation, and it's really very useful. I have even done this hydro implant for implanting the phakic IOLs also.
It should even manage to enlarge that rexus under hydro implantation.
Yeah, that was very good.
This is the hydro stitch cannula I said. So it has a tip like this, bend at 180 degree almost. So its advantage is that you can easily hydrate all the walls of the incisions like this. So you can easily just rotate to the other side. See, it's very easy to hydrate all the walls. I'll rotate my hands and it goes fit in there. And you see the pressure is fine and
Pressure is absolutely fine. The fold also
and you should take care that once you take off the speculum, you should always look for that there no rotation or anything which is not going to be there. So that finishes the case.
Very nice, very smooth, very good.
Thank you very much.
You showed additional tips and tricks about hydro implanting, about how to enlarge the rexus. And I think that cannula is really very good, especially for hydrating the wounds.
Yeah.
So this lens is a clear lens, Harshul, with zero angulation.
Yes, ma'am. Yes. And for years we have been using these IOL toric lenses, and they're very, very stable, and they have a good stability in the capsular bag.
So what about the rotation? Have you encountered any? You would have done other companies also and this as well. So how do you think, does it rotate or?
It's at par with it is any other company, ma'am. I've been using this lens for last 6 to 7 years, and it's at par with any company lenses. I can vouch on it. So I think with the Indian companies, they also have the lenses, all premium lenses available now. We can always offer our patients whatever they want.
Yeah, completely.
So they are not deprived of being, astigmatically neutral.
So this hydro cannula that you use is what gauge? There is a question by Dr. Rupali Jain, 26 gauge or 25 gauge?
So this hydro stitch cannula, which I have modified, it's made by Ovation International here, no financial interest. It goes by my name, TAC hydro stitch cannula. It's 27 gauge cannula. It has a length of 25 millimeters, and it's bent at almost 80 degrees, so that you can easily, especially in topical cases where patients tend to roll the eyes upwards, or it's really difficult to hydro stitch all the incision, all the walls of the incision. This cannula is very helpful. And as I showed, it also gives very good flow of fluid when you're doing hydrodissection. So it's a multi-purpose kind of cannula. You can easily hydrodissect, and then you can use the same cannula bending downwards. As I showed, you can rotate the nucleus at the same time.
Very nice innovation. Wonderful.
Thank you so much, sir. So I think just 1 minute, then Dr. Pankaj is
Any risk of what do you think is the rate of PCO in these cases, in these lenses, with these lenses?
So with these lenses, with biotech lenses which we have been using for years, PCO rate, we found that it's almost at par with any other lenses.
Mhm.
These are, yeah.
And the ease of implantation, like, is it very rigid or it's as
No.
the other one?
No. It's very comfortable. As I showed,
Okay.
I did implantation. They come up. They're very predictable. Very predictable. There is no optic damage or haptic damage or anything with these lenses.
And these implantation is done
Once
through
it's
2.8 millimeter.
Yes, sir.
The implantation is done through 2.8 millimeter incision,
No,
right?
that was 2.4.
No, 2.4. Okay.
Yeah, 2.4. Yeah. So once in a while, you may damage the haptic with all the.
No, that's a different. That's
available. Yes, but routinely nothing happens. Yeah.
So
Yeah.
can we
There is an online calculator also. Biotech, it's from Biotech online calculator, and this calculator also takes into account the posterior corneal astigmatism like all other calculators are taking into account. So it gives pretty accurate calculations.
So is it freely available, this online calculator?
Yes, sir. Yes, sir.
Okay, so can we move to the next case, Harshit?
Yes, sir.
Somebody can.
Yeah, so Dr. Pankaj is ready with the next case.
We can have the case details first. Yeah.
Yeah. Can you advance the slide, please? Case 2. So case 2 is a 65-year-old female, and she has cataract in both the eyes. So right eye is a 19 diopter, and we have planned to insert ADOF lens. It's a new lens. It's a preloaded lens from Biotech, the iCryl cert, they call it. And it gives, so there's a new injector system also, which Dr. Pankaj will be demonstrating. So can you have the microscope feed, please? Yes.
Okay. Ocular. So, good afternoon, everybody. This excellent facility Harshal has made here.
Can you hear
Top
Dr.
of the
Pankaj?
line.
Absolutely, clearly.
You can hear clearly, see also very well. It's a pleasure to watch Dr. Pankaj do surgery.
Yeah.
Thank you, Dr. Pankaj. This was long due. So
Yes.
Yeah, this was long due, and I have shared OT with him
Yes.
a couple of occasions, but at that time I could not see it that well the way clearly I can see it now, and that's a privilege, I must say.
So this is the viscoelastic which I'm using is a combination of sodium hyaluronate with chondroitin sulfate.
Okay.
And the eyeball is nice and hard. Keratome. Actually, I'm one of the old school fellows. I normally use a coaxial IA cannula. So I don't use the bimanual, and also
Pankaj, they are not old.
No, we all use coaxial more often than bimanual. On a few occasions we do use bimanual, but most of the time we also use coaxial.
And I usually don't make a initial groove, because whenever I make an initial groove, there's always some amount of foreign body sensation and epiphora to the patient if I make an initial groove and make a triplanar incision. So I generally go with a direct stab incision. It gives much more comfort to the patient. And also what I generally use is a Inamura's capsulorhexis forceps, cornea, which goes through a 2.2 millimeter incision. Thick. Okay. So there's just one problem with this microfilament. Microscope.
The patient is moving.
Yes. So there's one slight problem with this microcapsular forceps. It gets some, after the 2/3 of the rexus is over, it gets slightly stuck in the incision when you open it near the incision. So the Inamura forceps, it behaves just like a Utrata forceps and goes through a 2.2 millimeter incision. I'm using a 2.2 incision. Now, basically, there are two hydro steps. One is the subcapsular delamination of the cortical cleavage, which is the most important. Second is the hydrodelineation, which I normally avoid except in polar cataracts. The more you delineate, the eye becomes more difficult. For the subcapsular delamination, you have to go just under the capsule and get the fluid wave going. There's a fluid wave which went behind. If you just press it on one side, it comes out from the other side.
It was very nice, very nicely visible.
And the excessive nuclear rotation is also something which I avoid, because then you're not able to control the nucleus. It starts moving too much in the anterior chamber. Now I'll be going ahead with the direct chop technique. And this is the same Ertley machine, but I'll be using a 2.2
So do you have different sleeves for these 2.2 and
Yeah, the sleeve is different.
Okay.
The advantage with Ertley is that it's like a cobra tip. The shaft itself is thin, but the holding is much better because the tip is wider.
Okay, yeah.
It's
a straight tip, right?
Yeah, it's a straight tip. Yeah, that's better.
Is it, what's the degree of the
30 degrees.
30 degrees, yeah, that's what I was also figuring out. Very nice tip, sir.
Okay. Again, there are two ways which you can go about. Like Dr. Herschel did was he made multiple chops and then piece by piece he took them out. The only problem with that is, God forbid, if there's a rent, then it's difficult to manage those small pieces. So what I generally do is I take out small pieces. क्या हो रहा है? पूरी नीचे जा रही है टेबल.
So, meanwhile, there is this question, Rajesh, of intracameral antibiotics, which Dr. Nopur has asked. Do you normally use intracameral antibiotics? I think Dr. Herschel did not see him using intracameral antibiotics, but do you use in all the cases, or do you like to use only?
No, these days I'm using in all the cases.
In all the cases, you are putting
intracameral moxifloxacin. Earlier, I was not using it, but these days I'm using it in all the cases.
Yes.
And, mainly because there's so many factors and publications these days that have come up with the use of intracameral moxifloxacin, the advantages of intracameral moxifloxacin. And so the purpose it keeps you safe if there's any litigation or any issue, that yes, you have followed everything that can be done in order to make the surgery safe.
So intracameral antibiotics, I think earlier they were advocated that you only use, there were studies to say that you use when there is a problem. But I think now most of the cases,
I think you also use in most of the cases, ma'am.
So So most of the cases, what to say, most in all
Yeah.
in all the cases we use intracameral processing. And I think we had done a study where we had you were also a part of it,
Yeah.
a study of almost 16,000 patients to say whether it does work. So I think Dr. Pankaj is back.
Yeah. Yeah.
Sorry about that. The just cable automatically started going down.
Okay. Okay.
Now we
We
are
had a
back.
discussion on intracameral antibiotics because
Yeah.
that meanwhile.
I'm also using moxifloxacin
Okay. Okay.
post-operatively just after the surgery. Yeah. अच्छा, मुड़ गया.
Sometimes these things do happen. Some attendant or somebody presses something and table starts going. But the patient becomes uncooperative. We can see so uncooperative. Once I had seen a patient becoming so uncooperative, the patient got up in the middle of the surgery, and so these things happen in your day-to-day practice, wherein we have to learn to handle these things, and that's what Dr. handling slightly uncooperative patient who is moving the head, moving up. So
I think that this is one situation where Phaco has helped us a lot.
Absolutely.
God,
Absolutely.
If we had an open chamber with her like this,
Yeah.
it was quite devastating.
Yeah. True.
So I was saying that normally what I prefer is I take small pieces and keep on eating them so that I have one chunk left.
Mhm.
If something happens, at least I can deal with that one large piece. If you make very small pieces and then take, and if something as a rent occurs, it becomes a bit difficult to manage with small multiple pieces around in the anterior.
Some people also take out one small chip, so and they say that it's easier to move rotate the nucleus inside the bag once you remove a small chip.
Yes, it gives a hold where you can rotate the nucleus very easily.
Yeah.
Through that.
Yeah. Yeah. Absolutely.
No.
What is your preference? Like we have seen two different ways of doing things. I mean, will you prefer taking a small chip out first so that the nucleus rotates easily, or you would like to chop the pieces and then emulsify? What is?
I also do the way Pankaj is saying. I just chop and eat, chop and eat, chop and eat like that.
Okay.
The space gets better and the red reflex also gets better.
Yeah.
And very rightly, Dr. Pankaj said that if there is a problem, then you can deal with it better because you've already eaten up most of the.
So I'm just putting some more of intracameral lignocaine. So patient is feeling a bit of pain.
That's very much needed actually in this patient because she's moving her eyes, everything. And
I need some what is your experience on phenocaine, which has got a combination of lignocaine with tropicamide and epinephrine. Some people are not dilating the pupil pre-op, just using phenocaine. What is your take on that?
I think it's useful. It's good. What's your opinion, man?
No, I will definitely dilate the pupil, and if it is not dilated, then use phenocaine.
Yeah.
Can't risk the having a patient with a small pupil and then taking the chance of getting dilated by phenocaine, because I know sometimes it doesn't dilate as much as we want to, even with the phenocaine.
It's sometimes useful in some of the patients wherein even in spite of all efforts the people dilated. The other thing is that the patient also becomes a bit more cooperative. The patient is a bit apprehensive. If you see beforehand, the patient is apprehensive and will be a bit uncooperative. Then in such cases, it is useful.
So now we'll talk a bit about the IOL which I'll be implanting.
Yeah.
the biotech, it is known as monomore lens. Monomore means it's a monofocal lens, but it has got a slight advantage of intermediate vision because it's not a diffractive lens. It is more of a refractive platform. And normally the EDOF lenses, HPMs. So the EDOF lens usually has a, if you see the MTF, it is like a very mild curve, which is a large curve. It doesn't have a sharp peak with the EDOF lens. With this lens, it has got two distinct peaks, sharp peaks. One is for the distance and the other is for 1.75 near ad. Now, this is the injector system.
So will you implant through 2.2 or you will enlarge it?
No, it goes through a 2.2.
Okay.
So first of all, the first step is to just advance this to, there are two stops. Take it to the first stop and then just don't push it further.
अरे table
The table को ठीक करो. And then
mind boss
put some viscoelastic above and below the IOL.
Okay.
And then also from front. The nozzle.
We'll shift it. I'll paint it. I'll drape it.
Once this is done, the third step is to close this until you hear a click. Now this is the
Yes.
click. Then the next step is to advance it further. And you can just check it also. It is nicely folding and going, and you take it to the last step.
Very nice demonstration, Pankaj.
Yeah.
All the steps.
And then you check the lens again, and then this is the rotation wheel. Just have to hold it in your finger like this and keep on rotating. It just rotates on one side towards you. And then everything is now set for the implantation.
So this rotation wheel pushes the lens forward?
Yes, and the lens is slightly now it's still, just see if it has come forward or not. Now it is there. Yeah, now it is there almost at the nozzle.
Okay. So further advancement will be done by rotation of that rotating wheel.
Yeah, once this backside is totally inside, then the wheel starts rotating.
Okay.
Okay.
So wound assisted implantation can be done single-handedly.
Because now you can inject it with just one finger rotation.
Yeah, yeah. So normally in screw system you require both hands, but here you can rotate it just by finger.
Incision large. So I always make sure that I don't distort the incision by using undue force, because a controlled slight enlarging of the incision is much better
Absolutely.
than an unplanned enlarging then it doesn't close properly.
So this is a slightly yellowish lens, natural yellow lens.
It has the chromophore in it. So now I will start advancing it. I think you can hear the click also.
Yes, you can hear that.
It's a very controlled kind of a
yeah. And most importantly, what I could figure out that with a single hand you can the lens. For any rotational thing, you require both hands. Like one hand you hold if you are doing wound assisted or maybe inside.
So again, it is a 0 degree angulation, 6 millimeters optic size, and 13 millimeters, I think, overall length.
And it's got good optics also. It has the Abbey number is 47. It's good for a lens. I think you can see the small rings or zones also.
Yes.
Can you see that?
Yeah. You can see the reflection. Yeah.
You can zoom it up.
Zoom करना है. Microscope को zoom करना है.
Foot pedal. Left side foot pedal.
We can see them. We can see them very clearly, in fact.
So the CCC is well covering the IOL optic, because PCO is another issue with these types of premium IOLs. Even a small amount of PCO can, make the optical quality go down drastically.
True.
So we have to be very careful about that. And what I feel is removing the viscoelastic from behind the lens is the key. Because if the viscoelastic is left behind the IOL, the bag doesn't close. What is the capsular bend doesn't form, and the shrink wrap fit doesn't occur. So once the capsular bend doesn't form in initial 2 to 3 weeks, the rate of PCO increases then, because then the epithelial cells find their way inside the behind the IOL. So it's very crucial to remove all the cortical matter and remove all the viscoelastic from behind the IOL.
How do you think it compares with the other monofocal plus lenses that we have in the market when you compare this?
It's comparable to the eye hands. I've implanted the eye hands also, and it gives like what I usually do is make one eye emmetropic, the other eye minus 0.5. So it gives excellent results in that way. And patient, for his all practical purposes, is like spectacle free. Only if he has to read something very fine in print, only then he needs at the most +1.
So the idea is that the patient will not require spectacles for monitor work like mobile, like laptops, etc.
Computers and all those things. He can do, and he can drive. He can see his mobile phone. He can see most of the daily tasks can be done.
Very, you are very composed and very cool. The patient was so cooperative.
I've been operating in the government setup, and 50% of the patients are like this, and they are very, agitated most of the time. So if I lose my composure, then my health will go down.
So as you said, cool. We always call him Guru Cool. He is one teacher which all the students, they always respect him for years. Like it's been 20 years I was his student, and still I'm his student. Thank you so much.
Pankaj is a great teacher of teachers, I must say. And all your students that I meet, Pankaj, always say this. Always say this.
Yeah.
Thank you so much. Thank you. So with this we come to the third case.
Yes, ma'am. So third case which we are going to do is, can we see the sheet of third case? Yeah.
Yes, we can see that.
Yeah, so he has bilateral cataract, and we are going to operate left eye, and we are going to implant trifocal trio lens in this case. Can you see the microscope feed? No?
Yeah, we can.
Yeah, we can see that.
You need to focus it, but we can see it.
Yeah. So no.
So would you like to put the incision on the steep axis?
No, I always keep my incision at 180 degree.
Mm-hmm.
This is left eye. I'm sitting temporal.
Mm-hmm.
Saline. And my incision remains same. लाइट में देखेंगे बाबू जी, लाइट में देखिए बस. So again,
the reason why I said that the patient has a one diopter of cylinder, no? So that's why I was just thinking that maybe.
Yeah. So this is again 1.2 millimeter incision. So always try to keep these two side ports 180 degree apart, so that you can always get advantage of bimanual. And after that, again I put the Oculan or Phenocaine Plus. So nowadays, Phenocaine Plus is a very good option wherever you have, dilatation which is less. So it's always the first line of attack. After that, again,
One thing that has happened, Rajesh, now is that instead of putting intracameral adrenaline, we keep, phenocaine
Yes.
ready.
True.
rather
Very
than
true.
substitute
Very
the
true.
salve.
Very true.
So again, I go ahead and make 1.8 millimeter incision and put again viscoelastic cannula. Is it centered there?
Yeah, yeah. Absolutely well said.
Forceps being American. So I initiate the rexus with cystitome and just would like to show the rexus forceps also. And so one should always have all these things in their armamentarium so that wherever you need them, you can use. So this is the micro-axis forceps.
So this is the same microforceps which Dr. Pankaj was using.
Yes, yes.
Now, Mura, I have heard it actually. I'm sure it must be there, but we use Atratra forceps and had heard of Haldipurkar forceps, but this looks a very nice forceps to me.
Yeah, I tell you the another advantage is it's just a matter of getting used to it. So another advantage is that it goes through side ports. So if I want to go from here, you can see,
Yeah.
I can very well go from here and I can. So whenever you are stuck in situations, it's very useful. You should try different things,
Yeah.
Yeah.
So whatever I want, I can just go from this port also. And finish it.
I just want to make one comment on this forceps. The Inamura forceps is just like a Utrata. It has got long and thin blades which goes through 2.2 mm. The Utrata, if you take the through a 2.2 mm incision, it will not be able to reach the opposite side.
Yeah.
Right.
So, so the Inamura is similar to a Utrata, but very thin and very long blades. But this forceps which was used here, this is a which can go to the side port, but the problem with that is when you are near the incision, it gets stuck in the incision sometimes.
Yeah,
When
so
you open
that's
it,
where
close
you can
it.
go from side ports also,
Yes.
wherever you
Yes.
want.
Yeah.
That's what I wanted to
yes,
show.
exactly.
So here again, this hydro stitch or multi-purpose cannula, you see, I just go ahead and take out some viscoelastic before doing hydro dissection and turn it one side, and you can see the wave.
Yeah, yeah, we can see the way.
I turn the bevel on other side also, and the another advantage is I can turn it sub-incisionally and hydrate here also. So whenever you have cases which are softer and you're not able to do proper hydrodissection, you can always go sub-incisional.
Yeah, it's good. And you showed that how well you can rotate the nucleus as well with this.
सीधा देखने like the sharp वाला देंगे सब.
So this OptiFlex trio, this can be implanted through what size of incision?
Same 2.4 or 2.6.
Okay, okay, nice.
Yeah. I take off whatever exercise there and keep a good hold and chop it.
Very nice.
So as Dr. Pankaj said, we don't need to do vigorous nucleus rotation, because we know that once the wave has traversed, so the advantage of this tip is, as I said, is the cross-sectional area of the front is very large. So you get a very good hold. You see here,
Yeah, the hold is very good. Very nice hold.
and you can chop it nicely. Lens pulling it, please.
Chamber is quite stable. Everything.
Yes. So the smaller the incision is, you get a better chamber stability,
Mhm.
and then you can work faster and easily without.
I think we have to get Inamura forceps, definitely, Rajesh.
Yeah, it's very good.
Mm.
So in every surgeon, we feel that there's something, some few tips always they're added, and it's I consider myself very fortunate that seeing these surgeries we can learn and we can polish our own methods.
Quite right.
So credit goes to Namrata ma'am and you, Dr. Rajesh, for initiating these webinars and making it available all across India and world. That from any OT you can reach to the audience which is there worldwide. That's a great initiative.
Thank you so much, Harshul. I think the idea was this only, that people who can't reach up to the conferences or can't reach your ORs, but they idolize you and they see your surgeries, actually watch them with the click of a laptop or a desktop.
And
So
thanks to all these newer, technologies like Zoom and the
Yeah.
high-speed internet which is available, which has made this possible.
Very true.
So Harshul, there's a very tricky question, and that is what is the advantage of doing a 1.8 Phaco
Yes.
if you have to enlarge the incision for implanting an intraocular lens?
Yeah, so this is the session which is sponsored and by Biotech. They are doing it. So we have Hoya lenses. I don't enlarge the incision, just finish irrigation, aspiration, put it through 1.8.
Yeah.
So we have lenses available. And moreover, I tell you another advantage. As I told that we have better chamber stability. I can work through smaller pupil as compared to 2.8 or 2.4 or 2.2 tip, because relatively with 1.8 tip, you don't need much larger pupil, no?
Hmm.
So there are various advantages.
Yeah, that's very true.
I think there's
If we do live surgery with Hoya, I'll show without enlarging this incision with 1.8. So it depends on the type of the lens which we are using.
So there's another question, that in the presence of a PCR, would you still inject moxifloxacin, and would it cause any adverse event, to the retina? I don't think, none has been reported so far. There were a few cases of reaction which were reported if you use moxifloxacin intracamerally in a dose that is not recommended, in a higher dose, or use it in a quantity that is, not recommended, that is in a higher quantity. But otherwise, it doesn't have any adverse effect on the retina. As of now, there is no published study or case report of the same.
So you see the chamber stability. These are the lens here.
I think one thing which we should not use if there's a rent is methyl cellulose inside the eye, because that causes a lot of reaction with the vitreous.
True.
So
Yes,
either use
true.
chondroitin sulfate based or a sodium hyaluronate based if there is a rent.
Which intraocular lens will you use in this, Harshal?
Yes, ma'am.
Which lens are we using in this?
I'm going to implant a trio trifocal lens from Biotech. So this lens is like they're totally, I think it's manufactured in Ireland. That's what they say. It's an imported lens from Biotech, and been using for many years now, and it gives wonderful results. It's a preloaded lens. It has 12 rings on the anterior surface, and
Is it is it the same
This is
injector?
same injector system, it appears like.
so we just, the injector is slightly different than that. So I just put OVD here,
Okay.
and I'll just,
Is it not the same as
I said, no, with IQ 36, you can see the rings.
Yeah, the ring.
Yeah, we can see that. We can see that.
So this is the Optiflex Trio.
Yes, ma'am.
Okay. So we've been using Optiflex Trio also with very good results. Nearly completed about 40 lenses.
I think this is the injector which is manufactured by Medicell. That's what I know of. So so again, in controlled way, the lens goes in.
Yes.
You protect the optic from any mimicry.
And you have this dialer. I think this is Leicester.
So this is the Leicester hook, and which has a ball tip dialer, and you can see it goes in bag.
I remember this was introduced to us by, Pankaj would remember, by Professor V.K. Dada during his times, the dialer.
Yes.
Pankaj, remember?
Yes, I know.
The ball tip, he was very fond of
Yes.
it. And
And
nice to see it after so many years again.
And it really works very well in small pupil. You can
Yeah.
retract the pupil all 360 degrees with it.
So again, you can see here that the overlap is, what I feel is slightly more here. So I'll again like to, but slide में देखेंगे बाबूजी.
So Harshul is very fond of symmetrizing the overlaps, huh?
Yes, we should always look for perfection if we can get it. So it's always better to err on the to making your accessory a smaller size rather than large, because you can always enlarge it to. Now we have perfect overlap. Hydrostatic enlarge. And you can always check for the centration of the lens. Light में देखेंगे बाबूजी. Can you see these 3 lights there?
Yes, yes.
बस हिलना नहीं है बाबूजी. So these are the 3 lights of the microscope. So the first, the brighter are the from the anterior surface of cornea, and the light में देखिए सीधा light के अंदर. हाँ. And the inverted one are from the posterior surface of the lens, and
And about 4.5 millimeter of the size of the IOL must be having these rings, no, diffractive rings.
It has on the 4 millimeter.
Yeah.
And you can always turn the light on the coaxial, like these. Now, patient will see two lights, and you can see that these lights are coinciding. So that also signifies that lens is. So again,
centered.
to hydro stitch. लाइट में देखेंगे बाबूजी बस नहीं हिलिया नहीं
And the size of the central ring is how much? It should be about
more than ring is 1.12 millimeters here.
Okay.
So I think till 0.5 or 0.6 millimeter of angle alpha.
Yeah. 0.5 of angle alpha will be taken care of. So that
is the case. You can see lens is very well centered.
Yeah.
And perfectly is there. So with this, I finish my case.
Thank you.
So next we have case from Dr. Mayank, and he'll be implanting a phakic lens, the young patient. And by the time they drape, you can take questions, whatever it is.
So so there is a question on the YouTube again, that what is the size of the pupil that you're looking at would respond to if you give intracameral epinephrine or if you give intracameral phenocaine?
So I think first thing, it depends on the skill and comfort zone of the patient, of the surgeon, sorry. That if surgeon is comfortable, I'm comfortable if I can make my rexis of 4.5 millimeter, 5 millimeter, I can get away with without using expander. But anything less than that, if I'm not able to make rexis, of course, I like to use Mulligan ring, which is my preferred pupil expander. Phenocaine plus is our first line of attack. Wherever we see that pupil is small, we use Phenocaine plus, and if it doesn't dilate, I don't go and do stretch pupilloplasty or whatever. Just go ahead and put Mulligan ring, and that makes the surgery safer, and your comfort level is very much there.
About you, Pankaj, your go-to is also Mulligan ring or nylon hooks, like I can say for myself, that if the pupil doesn't dilate, then I like to go to nylon hooks, not so much Mulligan ring, because again, in a government setup, they don't pay for the Mulligan ring, so nylon hooks do well.
No, what I meant, my preferred choice, but of course, my message is that whatever device you want to use, either iris hooks or whatever device, BHEX thing, whatever you want to use it.
First of all, I would like to say that any non-dilating pupil should be treated as IFIS. On the if it is not dilated beyond 4 mm, that means there is high chances that it could be IFIS. Even if it's a male or a female, any person could have IFIS. It's not just the patients who are on the drug alpha blockers. Now, having said that, I use pupil expanders maybe 1% of the time, because usually I can do away with even small pupils as small as 3 mm by using that same the dialer, by retracting the iris, doing the rexis. Now the problem with that is, if you have done the CCC and then you want to expand, it is next to impossible, because whatever your expansion devices will get stuck in the CCC also. So as soon as you enter and you feel that the iris is also floppy, then you use expander. Otherwise, you can do away with using expanders, because the type of setup I'm working, it's not easy to get expanders like that. So what we do is we keep our own expanders, iris hooks, and if there's slightest chance that the iris is floppy, then I use a pupil expander.
These expanders, although the company says that it is disposable, but many times we reuse it.
Yes.
Do it, and it can be used for.
Yes, we can eat
or 5
and
cases
then-
easily.
And
Yeah, so-
I believe Herschel is also using them again.
Yeah. So as rightly said, I use
Actually, I had told
malignant
Dr. Milyugin only in one of the webinars that although you may not like it, but I eat you the Milyugin ring and reuse it in 4 or 5 cases.
Yeah. So if you see from that angle, it comes out very cheaper, It
Yeah.
costs 10,000, but you can use it in 5 cases easily. So at least that saves you money also. So whatever device one is comfortable with, one should use it. The only thing is,
Yeah.
and if you reach to the comfort level of Dr. Pankaj, of course, you can do
anything.
without expander also. So
Yeah.
in initial statement only, I said it depends on the comfort level of the surgeon.
Absolutely. Absolutely.
But whatever you choose, you should take care that in the end, you should have a rexis, which is perfect size, because these lenses, spheric lenses, multifocal toric, you need perfect size of rexis to lock them properly in the capsular bag. So if you leave rexis, which is very small, you'll end up in trouble if you make it very large. So once you have dilated the pupil with any expander, you can easily visualize that what is the perfect exact size of your capsular rexis.
True. Very true.
And moreover, if you have a cataract which is NS grade 2, 3, which is easy to chop, you can do with smaller. But if you have a softer cataract, they are a little bit problematic.
Yes, if you have a soft cataract and it becomes a small bowl and it is hidden behind the iris, then it becomes very difficult to get the peripheral handle of that bowl and bring it to the center. So you have to be very careful that the first chop has to go through and through, and the 2 pieces have to be made in the first go in small pupil. If you are attempting with a small pupil without expanders.
There's another question that if you injected the Oculan once and the patient still becomes uncooperative, say in the middle of the surgery, can you inject it again so that the patient becomes a little more cooperative?
Yes, I just shown that it can be done again, because Oculan is very safe for the endothelium, for the iris, for the intraocular tissues also. So you can give a 0.2 ml again, so that the patient becomes comfortable. One thing should be avoided is I see some people, they say that put some more paracaine in an open eye. So that should be avoided. You can use the same Oculan over the eye surface also, but don't use eye drops in an open eye, because they've got preservatives.
That is a very important message to be given, not to put propagate eye drops in a eye which is open where incision has already been made. Okay, Harshul, you do everything in style and your backdrop is also done in style. I must congratulate you for such a beautiful backdrop that you have done.
Thank you so much. It has been sent from your office only.
No, but it is.
So thanks a lot.
Nice. It is looking very nice.
He was showing off his enlarging the CCC because he has just saved about 5 crore rupees on the femto laser.
Okay. Okay. So I think the next case is your phakic intraocular lens.
So Dr. Mayank is ready with his case. So we can switch over to this. Can you show us the sheet, please? Yeah. Dr. Pankaj, please. Dr. Mayank. Yeah.
Okay.
Please tell us about this case. Yeah.
Good afternoon, everyone. Good afternoon, Namrata ma'am. Good afternoon, Rajesh Sinha sir.
Hi, good afternoon.
Good afternoon, Mayank. Yes.
Thank you, sir. So this is a young female, 21-year-old, and she came to me for a LASIK surgery, and her refractive errors are just -4 diopter sphere and -2.5 diopter spheres in the left eye, -4 in the right eye, which is I'm operating. But on topography, she was found unfit because the cornea is very thin. But her ACD is good, 3.23 are the ACD. So I decided to do a phakic IOL in this case. So I want to give a message that for lower refractive errors, still ICL is one of the choices when your patient is not fit for any keratorefractive surgeries. So, Anu,
Very
lightning
true.
go, beta.
So the maps have ruled out evidence of keratoconus in this
Yeah,
case?
the maps have ruled out all the keratoconus. I have been following up this kit since last 3 years time. And on 3
Okay.
serial topographies, she has no evidence of any keratoconus.
Okay.
Like, देखो बेटा, ऐसे ही रखो.
I
So I'll be
think,
making 2 side port first.
yes,
Is it centered?
yes,
Yeah,
yes,
yeah.
perfect.
A little bit of phenocaine or oculan so that the patient cooperates me well. And I'm using an HPMC only. I'll not be filling the chamber to it full. Main incision. This Biotech phakic IOL goes through a 2.8 millimeter incision. I'll be making a clear corneal 2.8 millimeter incision. And just enlarge the inner lip a little. IOL.
So Rajesh, I remember you had done a study on ICL versus LASIK in mild to moderate myopia or moderate to severe.
Yeah. Moderate to severe. Yeah. Moderate myopia.
Where you had shown very good results with ICL.
Yes. So in that study, we noted that the quality of vision was significantly better with the phakic implant.
So this is a phakic IOL by Biotech.
Yeah, this is a hydrophilic acrylic lens, right?
It's a hydrophilic acrylic lens, and it has a hole on the left leading haptic and a right trailing haptic. Is it visible clearly?
Yes.
Yeah, it is.
Yeah. And we have to put this lens in an open butterfly shaped cartridge. It is a normal injector. Is it okay now?
Yes.
There we can see.
So you have to put it on an open butterfly type cartridge, left leading haptic, and the right trailing haptic has holes. Just press it in the center.
It's very essential to understand this thing, that which leading haptic will have a hole, because companies have different makes, and that is very important to understand when you are implanting a
And
phakic.
this is normal routine Biotech injector.
Yeah.
You just see that it has been folded well and into the nozzle.
Yeah.
बेटा लाइट में देखते रहो. Line on cornea. लाइट में देखो बेटा. अनु लाइट में देखो बेटा. Is it centered now?
Yes.
Yeah, centered.
It's not going today with a 2.8 millimeter. I have to enlarge a little bit. Give me a second.
Yeah. With this injector, if you are doing a 2.8, then you'll have to do a wound assisted implantation.
I don't want to do a wound assisted in any of my phakic IOL cases, because in case you have to withdraw it, If
Yeah.
the lens accidentally opens upside down,
Mhm.
then there is a problem. So
Yeah.
I always prefer to get into the anterior chamber
Yeah.
and then inject it. बेटा लाइट में देखते रहना है ना 2 मिनट के बाद.
I think more so also you don't want any struggles, especially in a eye with a clear lens, you know, injecting a phakic lens. So it is always better to
Yeah.
the larger side of the incision than smaller.
So you keep an eye on the बेटा लाइट में देखते रहो. On the left leading haptic and never try to inject it below the iris. Always inject the IOL into the anterior chamber.
Yeah, that is something which is a very good point that has been brought out, that it should not be implanted straight away behind the iris. It may rub the capsule, it may cause some damage to the lens.
Protect the endothelium by
This is
injecting.
a spherical implant, right?
It is spherical because the patient has only 4 diopter of spherical error only.
Yeah.
Light में देखो बेटा. कुछ नहीं होगा बेटे. You go to the foothold of the lens, foot plate of the lens, and just tap it down. It will automatically go. बेटा लाइट में देखिए. बेटा लाइट में देखिए. Saline on cornea, please.
I think the lower part is already behind the iris and only the upper part has to be put behind the iris.
So with the manipulator, touch the foot plate. Then it goes.
Yeah. So I think that was a very useful step that you showed just now, exactly where to, you know, exactly where to manipulate it to get it into the correct position. Because if you are a little more distal, then it doesn't go in, or if you are more proximal, it doesn't go in again.
आइए please.
So are there any, this also has a central hole which is present. And so a peripheral adenectomy is not required for these cases also?
Yeah, ma'am, it does have a central hole. As you can see
It does
there.
have a central hole which is 360 microns and 2 holes at the periphery which are around 500 microns. So PI is not needed, and we have not seen any post-operative glaucoma cases with these phakic IOLs. Initially, yes, for a few days we do give some anti-glaucoma, that too for a week or 2 weeks time. बेटा जोर नहीं लगाओ.
Actually, it is, you know, you can aspirate the viscoelastic from underneath the vault as well because of this central port. That is also an advantage, that don't leave any viscoelastic because of the central port.
So because of the presence of the central port, which is there in this lens and several other phakic lenses also, do you think the patient ever complains of some kind of distortions or some kind of
light में देखो जोर नहीं लगाओ.
rings
Yes.
that-
Yes, a few patients, very few patients, they by themselves, they will tell you. Otherwise, most of the patients, they will not complain. Occasionally, if you ask somebody directly, and if he starts thinking, then maybe a small percentage can further be added in terms of, you know, having complaints. But by themselves, most of the patients, what I have felt, they don't complain about anything. Very few patients, they do complain of like thing or some shadow kind of thing. So a little bit of glare.
Rajesh, if you had a, for instance, hypermetrope would you still not do a PI, or would you prefer to do a PI in those cases as opposed to a myope when you're doing any phakic IOL?
Yes, that is something it's a very good question, I would say. In hyperope, yes, if it's even in myope, if it's a borderline kind of, say if it's a 2.8 millimeter AC depth, in such cases, I may think of a 2.8 or 2.7 also. Once in a while, I've used it if the angle is very much open. In such a case, I may prefer doing a small PI. In hyperope, as well, if it's a reasonably good, decent AC depth, then I may not do a PI, but if it's a borderline kind of a AC depth, which we can get in hyperope, then in that case, we may think of doing a PI.
And Dr. Mayank, do you put pilocarpine at the end of your cases?
Ma'am, not necessarily in all cases. When the pupil is very much dilated, yes, but this sort of pupil, I don't want to put a pilocarpine.
Yeah, we don't like to put because it may affect the vaultings. Yeah.
Yeah. It will affect the vaulting initially. Yes, that's very true. And the second thing is that you may remove, because these are dispersive viscoelastic. So you removal of 100% of viscoelastic cannot be guaranteed in every case. So if the pupil is nicely well dilated, then a little bit of few fibrils here and there, viscoelastic can just get drained from the aqueous. Otherwise, sometimes what happens that if you make the pupil very small, then there can be collection of some fibrils of viscoelastic that can swell as well.
Yeah, I think Dr. Rajesh has brought out very important point that it's very essential that you try to remove almost all the viscoelastic, because that's the main cause of increase in post-operative IOP and all those reactions in these cases, phakic IOLs. So I think Dr. Mayank is done with this case. We can
very
have
nice.
Some discussion.
All the 4 cases very nicely done, and
really, I mean, this is worth applauding.
Thank you so much, ma'am.
And some very essential tips, very important tips given by all 3 of you, and it was a very good learning experience for us. And we surely believe that everyone who is watching must have few messages, a few tips, that will polish their own method.
Yeah, so I think this is the best way to teach younger surgeons if they see it live, that what's happening when the iris is coming out, how the surgeon is handling. So these are all very important tips, finer tips, which you don't see in edited, version of the talks.
Absolutely.
So Surginar definitely has, I think it comes number 1 in teaching. It has the biggest role in teaching the younger surgeon. I'll request Dr. Mayank to come here. And before we close this session, I'd like to once again thank entire Governing Council of AIOS, Dr. Namrata Sharma ma'am, Dr. Rajesh Sinha sir, Dr. Lalit Verma, Dr. Harvansh Lal, and everybody for giving this wonderful opportunity today to showcase some of the surgical tips here. And I'd like to thank Dr. Pankaj, my teacher, Dr. Mayank, my good friend, Secretary of JOS, and biotech people for taking care of this entire webinar, and Artli Toshbro, my OT assistant, Mr. Kamlesh, Mr. Shakti, Rajivji from Ikegami Camera. You saw the transmission that was done by Ikegami full HD cameras, and Dr. Bhanvi, my fellow, and the audiovisual team from Swarnim for making it flawless. And
I've remembered every name actually.
I know.
So that's what only I practiced for last 2 days.
Surgery you knew you would do at a spinal level. All this you need to practice. But we had a very good question. Really.
When I have my teacher with me, I don't have to be afraid of anything. Dr. Pankaj.
Yes, thank you, Harshul, for this wonderful opportunity, and thank you, AIOS, for giving this opportunity to everyone. I remember Dr. Tityal had come here. He had operated a multifocal IOL, and when he injected the IOL fractured. So everybody said they don't change the field. We want to see what he's going to do. He beautifully showed how we can remove the IOL, and he implanted another IOL. It was amazing. And I think this can only be learned by such life surgeries only, where actually when you see the surgeon, how he tackles with a difficult situation. And so I think it will go a long way in teaching young ophthalmologists how to handle not only the best scenario cases, but also the complicated and the cases where we have complications.
And also the uncooperative patients.
Yes.
Thank you.
Thank you very
Namrata
much.
ma'am. Thank you, Rajesh sir. Thank you, IOS, for giving me this opportunity.
Thank you.
Thank you,
Thank
everyone.
you, Khalsa ji, for doing up this show.
Yes.
Done so well. And I would like to congratulate all of you and Biotech. Harshul, we've had one of the highest viewership today. I don't know for reasons, for what. I can't pinpoint the reason, but I think it is because of the galaxy of the surgeons that we had today. And even on the Facebook, YouTube, everybody is congratulating you for those great tips. And me and Rajesh have also seen some of the new things which we were not aware of. And, you know, like I said, there are people from Nepal who've joined in, and they want to know how and where they can get the forceps that we talked about. I think the true sponsor is the forceps today, Inamura forceps. So thank you very much for everything. Thank you, Mr. Kripal, our AIOS headquarter team, Mr. Gaurav and Swarnim for the audiovisual backup. And we cannot thank our sponsors, Biotech, Mr. Khalsa, who's always ever cooperative. I'm sure not only with us, but with everybody.
And
And Toshbro.
Yeah, and Toshbro, of course. Toshbro is a surprise element. Toshbro very rarely does live surgeries, but I'm sure their machine was shown so well by the two surgeons, Dr. Harshul and Dr. Pankaj. The way the machine worked was really wonderful. So thank you, all of you, and we hope to have you again, Harshul. And of course, Dr. Pankaj and Mayank. Pankaj, we need to do one from SMS.
Yes, definitely, definitely, Namrata. And the Inamura forceps is available with Amazon. So anybody can buy it from there.
No financial interest?
No, you can claim a little bit. Thank you very much. And thank you, Rajesh. I always forget to thank my co-moderator, Dr. Rajesh Sinha, a dynamic surgeon and, of course, person par excellence with great organizational skills.
Thank you, ma'am.
Thank you very much, Rajesh.
Thank you, ma'am.
Thank you all. Thank you, everyone. Bye.